My name is Judy True, and I will be one of the moderators for this session. Nighttime emergencies, things that go bump in the night. And so my co-moderator here is Dr. Mohammed Bilal, who will be giving his first talk. He is the Associate Professor of Medicine at University of Colorado, as well as the APD for the Advanced Endoscopy Fellowship Program, and then Director of Third Space and Bariatric Endoscopy, and he is going to be talking about GI bleeding.
Thank you so much, Dr. True, for this introduction, and thank you to AGA and DDW for this opportunity. It's truly an honor and privilege to talk about something that is very near and dear to my heart, and also something that we all deal with, GI bleeding, and how and when to position new tools. If I can advance, these are my disclosures. So, every GI bleeding talk has to start with a Forrest classification, and I think it's important because it sets the stage of where we use these tools to intervene, because not every GI bleeding needs intervention, or every ulcer that we see needs an intervention. So as you can see over here, that the Forrest class 1A, 1B, 2A, and 2B lesions are the highest risk of having rebleeding. And that's really what we care about, is do they have high risk stigmata that they can cause rebleeding? And these are the lesions that we intervene upon. Since the medical management is beyond the scope of this talk, so I'll jump straight into what we need to do when we're doing endoscopy. So what are the basic principles of endoscopic management? You cannot treat what you cannot see. So it's really important for us not to just know our tools, but know how we can improve visualization. So if it's a significant upper GI bleeding where patient is having ongoing nausea, vomiting, and coffee ground emesis or hematemesis, it means that there's going to be blood in the stomach, and when you go in, you're going to have a hard time visualizing because of that blood. So I always recommend in those cases using a prokinetic, always give erythromycin IV, understanding how suction and what tools we have for suction in addition to our run-of-the-mill scope suction. And then using a clear distal attachment cap is critical, especially in tough locations like the duodenal bulb or the D1, D2 sweep, because it allows that extra little stability that can allow you to deal with these. And then one thing that was oftentimes underutilized in management of GI bleeding is position change. And then our toolbox, I love this mnemonic, it's called CLOTS. So we have clips, we have ligation, again, optimized visualization, thermocoagulation, and sprays. So getting right into for GI fellows, this is what I always teach them when managing GI bleeding. I say, think about the big four. When you're doing an exam for GI bleeding, don't spend too much time in the esophagus. If you see blood, you rule out the big four. Are there pathology, the G junction? Are there varices, Mallory-Weiss tear? That's kind of the area, G junction, proximal cardia, where you'll see dilophoid lesions. Fundus, are there gastric varices or dilophoids, antrum ulcers, and duodenal bulb. And then if you don't find a source, but you see blood in the stomach, then you can spend more time looking at it. I can't tell you how many times I've gone in to help my colleagues in a room where they're spending time clearing the fundus and have not gotten to the bulb, and then, they can't find the source and think it's a gastric varix or something, and we go in the bulb and there's a large duodenal bulb ulcer. So that really helps your efficiency of your exam. And then visualization, just like I said, the ACG guidelines recommend using prokinetic therapy, erythromycin, for these patients. There's less evidence, but doesn't hurt much. And then what tools we have available for visualization. We've seen enormous improvements in the last few years outside of our normal suction abilities. So this is a BioVac system that I frequently use in these cases that bypasses the scope suction. And then on the right, you see this Pathfinder, or the overtube system of suction, where you basically put the overtube and use the large caliber of the overtube to suction big clots and really improve visualization. This is a colon cleansing device that was developed for that intention, but now has been approved in the upper GI tract. So this was one of the first cases we did with this device and published in Endoscopy here. This is a power irrigation as well as power suction. It has channels to do both, so it bypasses the scope ability. So here you'll see these water jets that are coming around, and you'll see this bleed in the proximal stomach or cardia region, which is really obscuring visualization and making it hard for us to treat this bleeder. But with using the power suction and ability, we're really able to clear out these clots, as you'll see here, and even clots as big as this and this will help us localize the bleeding here, and we can then intervene and treat upon it. So the reason for showing this or highlighting this, and here you'll see it's like we now have a really nice view of where the bleeding is coming, and we've already tried one clip. It hasn't given us hemostasis, and we will put another clip over here in a second, and then you'll see here that we'll get really nice hemostasis. So important for us to know that there's all these tools available. You may not have access to all of them in your suite, but that's when the poor man's technique of improving visualization is so critical. That we have learned a lot about this from our work in advanced resection and ESD, but changing the position. So this is your classic left lateral position where the blood pools in the body in the proximal fundus, and then when you change to the right lateral position, then it changes your field of view of the blood, and the clots will now move to the antrum, so it makes localizing bleeding in that area easier. So very simple to do, hard to do in the United States when we're using a lot of anesthesia, but other parts of the world often used. This is an article from India that I really like. It was published in Endoscopy International, where they showed the use of a left lateral semi-recumbent position. And what that does is also does the same thing. It moves the blood away from the fundus to more to the body, and you can clear up the fundus. So depending upon where your source is, trying to look at these. And here you'll see endoscopies. Panel A is in your normal left position, and panel B is in the left lateral recumbent position. And you can see 3 examples that the authors have shown, which really improve your visualization. So let's put all this changing position thing together. This is a video from my great friend and colleague and master resectionist, Dr. Rob Bachara from Canada, where he's doing a polypectomy, a regular run-of-the-mill polyp, and removes the polyp and goes really fine. It's it's a run-of-the-mill. We all do these in our ASCs. This is not a challenging, our advanced resection, and all of a sudden you see this. Now the challenge here is that we know there's bleeding, we know the site, we're right there. But to be able to intervene on this polyp or polypectomy bleed, what you need to do is visualization. So the reason for showing this video is how important it is that visualization is important. So obviously colonoscopy is done in the left lateral position. So here you'll see that Dr. Bachara will convert the patient into a right lateral position, and then you'll see the difference for yourself. And then as soon as the patient is in right lateral position, you'll see the bleeding vessel, really nice visualization, still gets your heart rate a little up, but now you can see what things are going. And then, opening what we call as a hemostatic forceps that I'll go over here, which allows you to visualize the bleeding source easily, and then 2 taps on cautery, and a crisis situation has now become a really relaxed and comfortable situation. So simple, cheap, cost-saving intervention of changing patient's position. Now that you've optimized visualization, it's important to know what's in our toolkit. So we have a wide array. I feel like I didn't graduate fellowship too long ago, but one of my interns is now here co-monitoring sessions. It's probably been a few years, and that points us to the fact that our toolkit has enormously developed over the last 5 to 10 years, even since I was a GI fellow. We used to have epinephrine injection and thermal therapy, but now even for thermal therapy, we have soft coagulation, we have coagulation grasper forceps, and we have mechanical therapy through the scope clips and over the scope clips, suturing and hemostatic sprays. So how do we use it? How do we position it? Obviously still, I think clips are still remain to be, or mechanical therapy with through the scope endo clips still remain a very good option despite all the fancy tools we have, but it's important to know how to utilize them well. The benefit of clipping, if you do it right, is that it allows you, moment you grasp the lesion, especially if it's an active vessel here, you'll see, the biggest mistake that people do with clips is fire them too quickly. So it's important that you grasp the clip. This is a video courtesy of my friend and colleague, Dr. Tom Tillman from Southwestern. And you'll see here that grasp the clip, you can see the pulsating vessel, it means you got it. Sometimes you see a little ooze, that makes me feel a little better. And then you take your time, wash, make sure it's no more active bleeding, and then you can go ahead and deploy the clip as they do over here, and then you get hemostasis. The next thing in our armamentarium that we all know or are familiar with is using what we call as the coaptive coagulation, or with the gold probe or silver probe, what you have. So here you see an ulcer in the duodenal bulb, run-of-the-mill ulcer. The important thing in this, so you have to use coaptive coagulation, so it cannot be superficial. You really have to push the vessel and cauterize it. It makes people nervous and uncomfortable, including myself sometimes, because there's a risk for perforation. But that's the only way you're going to get hemostasis. So, but sometimes it doesn't work. So here in the same case, they tried a gold probe. So the challenge with this case is that they're using a 7 French gold probe. because that's the only gold probe or the catheter that will go with a normal endoscopic scope, like a normal EGD scope that most of us use, an Olympus scope or your routine Fuji or Pentax scope. And for large vessels, especially in the duodenum, if you're dealing with a branch of the gastroduodenal artery, you need really good coaptative coagulation, and that's important to use a 10 French devices. And 10 French devices are only compatible with a therapeutic scope, or what we call a modified therapeutic scope, or a 1T scope. So here you'll see that doesn't work, but now we have over-the-scope clip. So if this fails, the over-the-scope clip, or commonly called as the bear claw, allows you to go through and really grasp the lesion, suction, and deploy it. If any one of you can band a varix, you can use an over-the-scope clip. Almost all our GI fellows are now trained to do this, and there's a lot of other ways if you haven't learned how to use it to be able to practice, including courses at DDW and other national meetings. But the over-the-scope clip has now changed from where it was initially thought to be a therapy for refractory bleeding to a therapy for primary hemostasis, and there's cost-effective studies that we'll go over here in a second, and randomized trial that showed. So this is a bleeding case that I did where you'll see there's a bleeding vessel, there's no visible ulcer or anything underneath it, and I'm just going to go straight to over-the-scope clip, and you'll see here we easily get the whole vessel along with its base and underneath and get hemostasis. So it's absolutely fine to use over-the-scope clip as a predominant modality. What does the data show about over-the-scope clips? We have a good amount of data in the fashion of randomized control trials that show this. This was the first randomized control trial, one of the first randomized control trials that used over-the-scope clips for recurrent peptic ulcer bleeding. So these are challenging bleeds because they had already demonstrated that they bleed. And again, you can see significant difference in standard therapy and over-the-scope clips. And now we have also data from randomized control trial from Dr. Jensen's group, which actually shows as a primary modality for over-the-scope clip use. And again, only 4% recurrent bleeding if over-the-scope clips are used, whereas compared to 29 to 30% recurrent bleeding with standard therapies. To summarize all this, our group carried out a meta-analysis that was presented yesterday at DDW, thanks to our resident, Dr. Erica Loon, where we have shown the efficacy of over-the-scope clips through the scope therapies as a primary modality for treating non-variceal upper GI bleeding. But that's great. You got over the scope clip, you feel really good about yourself. So this is a case where I put an over the scope clip, and I go in, and all of a sudden I'm like, okay, that didn't help. And if anything, it made the situation worse. So here you'll see a spurting bleeding. It's after I've used the over-the-scope clip, which I used to think was probably the most definitive therapy. And the answer is that we still have more tools in our toolbox. So here, my fellow's looking at it, and I'm like, now it's time for me to take over. We're going to use a hemostatic forceps, and you just grab it, tent it, and here you'll see we got complete hemostasis. So even if you have recurrent bleeding after over-the-scope clips, sometimes that can really get the base of the lesion in, and you can be more aggressive with coagulation or thermal therapy on top of that. So hemostatic forceps. So hemostatic forceps is a really great tool, and we in advanced resection use it all the time, but it's really like using a biopsy forceps. So there's no reason that anyone who can do endoscopy cannot use this. So this is a esophageal EMR that I've done recently, and after I do this, and here you'll see the band is still there. We use a band ligation EMR for these patients for early esophageal neoplasia, and then you'll see there's a spurting vessel right there. And the first thing I do is I'm like giving a talk at DDW. I need to make sure I record it. Once it's recording, now I'm going to get the hemostatic forceps down. And once the forceps are down, you'll see the benefit of this is that it allows both control mechanically and thermally. So you close it, as you see the first time it didn't get hemostasis because it was still oozing when I closed the forceps. And then once I close it again, you'll see the bleeding has stopped. And once the bleeding is stopped, then you tent away because you don't want to be you don't want to be causing thermal injury on the back wall or the muscle, and you tent away and then use coagulation to grasp it. So again, the challenge in this case, as you can see, is that I'm unable to localize it because of visualization. But finally, we're able to localize it, and this is a really beautiful vessel. And you'll see here at the end that we get hemostasis, and you can even see it's like a little pipe, I looked at it for a while. So, but after all fails, hemostatic sprays are an excellent option for these things, especially for patients where, it's not focal, it's not localized, and you need more diffuse control. So this is a malignant, duodenal infiltration of a malignancy. Patient already has a duodenal stent, and now his bleeding is dropped 2 to 3 grams of hemoglobin to go in, and all I see is just bleeding. I'm trying to localize it. but it's not possible because it's coming from a diffuse area. So again, hemostatic sprays, we have a wide variety of them, as I'll go over here in a second. But this is the hemostatic spray, or the hemospray. That was the first hemostatic spray available. And again, you can just see that it diffusely sprays it. Very important, again, if you have an option, to use a larger caliber scope, because it allows you to get a 10 French catheter. And if you get a 10 French catheter, it's less likely to clog. So hemostatic sprays are not only fun, we have data in the fashion of randomized control trials, and several of them looking at hemostatic sprays with even as a primary modality as well as a secondary modality for refractory bleeding, again showing really good efficacy and reducing the rate of recurrent bleeding. A common misconception is that hemostatic sprays only temporizes the bleeding, but a lot of these studies will show that a lot of times you can achieve good hemostasis. So I don't think of it as a bridge to anything. Sometimes that's what you need, but sometimes I use it as a definitive therapy and patients do well. So we have almost 4 commercially available sprays in the United States, including a hemostatic gel, which is Purostat, which really helps with prevention of delayed bleeding. And our toolbox continues to expand, so it's really encouraging in end of GI bleeding in 2025. This is a case of endoscopic suturing for refractory bleed that I did. We published in ACGK Sport Journals a couple of years ago, where you'll see that we got suturing and the patient got rescoped 3 months later, and you can still see the cinch over here and looks completely normal in a patient with a refractory malignant ulcer bleeding that there was no way else to control. Sometimes bleedings are more challenging. Like in this case, you'll see here multiple diffuse areas of bleeding. Patients, tried APC, multiple areas, but still continues to have problems. And then here I'm using a spray cryotherapy catheter and, diffusely spraying this area because it's hard to treat so many different lesions. And we oftentimes see these patients and they're on blood thinners, and we really struggle with managing their hemostasis. Well, despite all this, there are cases that really humble you, and this is a video from one of my colleagues from Europe, Dr. Alexander Karvik, where he sees a large vessel, and you can see that the hemostatic forceps, and with his permission, we discussed that how this case could have been better, are bigger than the vessel itself. So that's usually a good sign that you need to use something else, but in the moment, we're able to manage this, and all of a sudden he touches and you can see all the bleeding in this case. And the important take-home message is that despite all these advances, some patients will still need IR and rarely need surgery. You need to have your trusted IR colleagues and surgery colleagues on speed dial, especially if you're going to tackle these patients in a hospital setting. And it's important to know, looking at some of the lesions, where your skill set or your toolbox or where endoscopy maximizes and we still need help. And this clinical practice update from AGA a couple of years ago really summarizes the same things we discussed nicely. So to summarize, for pre-procedure, using a prokinetic, especially for large upper GI bleeding, large volume upper GI bleeding can be helpful. Figure out your sedation plan. Are you going to need to intubate the patient? Are you going to be able to use MAC anesthesia, moderate sedation? Because all those things will come back. So pre-planning before a procedure is helpful. My favorite scope is a 1T scope because it's a larger channel and it's still flexible, but there are other therapeutic scopes that are available and more that are being developed. A clear distal attachment cap is critical and can really make it easier, especially in tough locations. Remember, you can't treat what you cannot see, so visualization is key. The best treatment modality is the one that works. Don't try the same thing again. As you saw, the sequential order of cases that I showed, that we had to keep advancing our therapies and call for help. You may have someone else in the room in a stressful situation who may come with a fresh set of eyes and may be able to help you. And sending to IR surgery is sometimes the only option. So thank you so much for your attention.
Thank you. We are going to move on to our next speaker, who does not need an introduction because we all know her, Dr. Nina Abraham. She is going to be speaking on acute upper GI bleed, when and what drugs to start and stop. And just as a reminder, we'll do a big Q&A at the very end. Don't forget to submit your questions through the app.
Good morning, everybody, and thank you to the organizers and our course directors for inviting me to speak about one of my absolute favorite topics. I have good news and I have bad news. What would you like me to start with? Okay. The bad news is, with the aging population, almost every single patient you're going to see is going to be on an antiplatelet and anticoagulant by 2030. In the United States alone, 60% of U.S. adults will be on one of these drugs, and that is the #1 cause for GI bleeding. So the good news is I'm going to share with you how to manage those patients when they inevitably bleed, because they will bleed. So let's start with there we go. One of my favorite cases. This is one of my personal patients in the cardio GI clinic who is actually the Arizona State Golden Paddle Pickleball champion. Now, she takes her pickleball very, very seriously, and she has a history of ischemic heart disease, atrial fibrillation on warfarin, and as well as has aspirin on board. She defended her championship successfully recently and took a boatload of NSAIDs to deal with pickleball elbow, which I didn't know was a thing. And then she came to the emergency room presenting with 3 days of 3 episodes of large volume melena over 24 hours. As you can see, she dropped her hemoglobin by 3 grams. She had an INR of 4.2. She was tachycardic and hypotensive. The ED gave her some blood and fluids, and she became hemodynamically stable, and they called the GI service. So what are we going to talk about today? Well, we're going to talk about patients like this. We're going to teach you how to learn and manage antithrombotic drugs in the periendoscopic period of GI bleeding. I'm going to emphasize what clinical considerations influence how you should manage these drugs. And I'm going to give you some pro tips from our clinic about what works, what is realistic, and what you need to tell the patient to keep them out of trouble the next time. So, as I mentioned, these patients are going to bleed. If an adult patient over the age of 18 is on aspirin, warfarin, or anticoagulant monotherapy or antiplatelet therapy, their annual risk of bleeding is 4.5%. That risk goes up with age and with the number of antithrombotic drugs on board. And you'll see here in the second panel, that's my patient. So she has atrial fibrillation and an ischemic heart disease, and her age is 65, so her annual risk of bleeding is predictably at 10%, which will go up to 17.5% when she hits 75. So the first thing you want to know when you see an anticoagulant bleed is to triage the patient, because that now differentiates the practice strategy. So how do you identify the patient with a life-threatening hemorrhage? These are patients with major clinically overt or apparent bleeds who have hypovolemic shock or severe hypotension requiring pressors. Often these are the folks you see in the ICU. Or if they're just a little subacute but they're heading down that path, they will have fulfilled what I call the rule of fives. They've had a decrease in their hemoglobin of greater than 5 grams, and they've needed more than 5 units of blood. Now, my patient didn't quite meet that condition, which is why she didn't get a reversal agent. And that's the key consideration. Reversal agents for anticoagulants should be reserved for patients who meet this definition. And that's because these agents are associated with a high risk of thrombosis when used inappropriately. So let's just pretend my patient had met that threshold. What would you have used? Well, the choice should be 4-factor prothrombin complex concentrate, which has factors 2, 7, 9, and 10, and will quickly reverse her anticoagulant load associated with the warfarin. We do not want you to use FFP because it takes large volumes of FFP transfused very slowly to even modestly decrease a supertherapeutic INR. And unlike the 2016 guidelines we wrote back, we do not want you to use vitamin K. And that's because the latest evidence shows that vitamin K just takes too long to reverse that anticoagulant effect, and we want you to get in there quickly because there's more than sufficient evidence to show that acting promptly within the first 24 hours of a GI bleed decreases morbidity and mortality for your patient. So if you're saying, what about vitamin K? That's because of the time it takes, and it doesn't matter if you give it IM or if you give it IV, it still works too slowly. It's also important to know in the situation of a warfarin supertherapeutic bleed that you do not need to normalize the INR to be successful. A lot of folks are still doing that. Do not be afraid of scoping these patients with a modestly elevated INR. So as I tell my team, if it's 2.5 or less, you're ready to go. And that's because we know that INR at the time of endoscopy does not predict rebleeding, and normalizing the INR does not confer this cardiac patient with any additional benefit, but it actually just delays the time to endoscopy. And in a cardiac patient on these drugs, that is so incredibly important, because if they're in that area where they're having a major GI bleed, in almost 83% of cases, when you drop that scope, you're going to see a high forest class lesion. That forest class lesion needs attention by you, because they then will end up going to the cath lab. And that's the temporizing step necessary to get them to the cath lab. And it's the cath lab that's life-saving for them, not us. We are merely there to facilitate their journey to the cath lab in 83% of patients. So please do not delay your endoscopy. Now, this patient had been on warfarin, and the knee-jerk reaction for many folks in hospital internal medicine is to start them on bridging. But there are very few patients who actually need to have bridge anticoagulation provided when their warfarin is temporarily interrupted. And that's because we now know from 2 very large randomized control trials in the cardiac literature, the BRIDGE and the PERIOP-2 randomized control trial, as well as 5 large observational studies that are very well done in the GI literature, that low molecular weight heparin bridging provided as a standard therapy to patients when their warfarin is interrupted is actually associated with increased post-procedural bleeding without thromboembolic benefit for the patient. So in whom should you be considering bridging? These are the patients with mechanical valves. That's not my patient. These are patients with atrial fibrillation and a high CHAD score. That's not my patient. These are patients who have a history of thromboembolism with previous temporary interruption of their warfarin, and then following certain cardiovascular surgeries and that immediate post-surgical procedure when there's a very high cytokine load that increases their thromboembolic risk. None of these situations represent my patient, so she was appropriately not given low molecular weight heparin before she went to endoscopy. If you do have a patient who fits that criteria, how do you bridge a patient? It is actually very easy, and it's a formula. Low molecular weight heparin is dosed by weight, and you give the last dose 24 hours before the procedure. You restart warfarin on the day of the procedure, and when immediate hemostasis is achieved, you restart the low molecular weight heparin. In a low bleeding risk procedure, that's usually 24 hours post-procedure, and in a high bleeding risk procedure, up to 48 or 72 hours later. Now, when should you be restarting the warfarin in these patients? Well, there's actually very little good evidence in the endoscopic setting in GI bleeding of when to restart. But when we did our 2022 guideline, we looked at literature from the cardiovascular surgery, and the neurologic literature, and the message was clear. If you restart warfarin within 4 to 7 days of discontinuation, it's associated with a very low risk of thromboembolism. So in the endoscopy literature, that risk of thromboembolism with that sort of window frame of time is less than 1%. So you want to get the patients back on their warfarin as soon as possible, but you do not want to be delaying these patients with no coverage of warfarin for beyond 7 days. But most of us can get this done within 48 hours, 72 hours. So by the time you've been turning off that IV PPI, that patient should be back on their warfarin. All right, for those of you who follow American football, you'll know who this guy is. And if you don't follow American football, if you've even heard of Taylor Swift, you'll know who this guy is. And this is to remind you, this slide was provided to me by my colleague, Dr. Alan Khan, who saw this and sent me this meme for my next talk, to remind you that when you have a direct oral anticoagulant, you should also be reserving reversal agents for patients who meet that criteria of a life-threatening hemorrhage. And that's because the use of these reversal agents inappropriately is associated with a pretty high risk of thromboembolism, anywhere between 5 and 30%, depending on the agent that's used. And that's been the downside of these agents when used indiscriminately in the hospital setting. People have clots. So that's why the 22 guidelines specify that these agents should only be reserved for patients who meet that criteria of a life-threatening hemorrhage. So if the patient has been on rivaroxaban or apixaban within 24 hours, you want to reach for andexanate alpha. Now, this recommendation is based on a single study with serious risk of bias, no control group, and actually very little GI bleed data. So I'm not a big fan of this drug, I'll be honest, because it has the highest risk of thromboembolism, anywhere between 12 to 30%, depending on the dose used. Plus, in the United States, it's incredibly expensive, and this cost is not covered by Medicare, so often the patient pays out of pocket. But again, if the patient's had that drug taken within 24 hours, it would be an appropriate consideration if the patient had a life-threatening hemorrhage. Dabigatran users can get great benefit from the use of idarucizumab. It's a great drug. It works really well. The risk of thromboembolism is only 5%, but unfortunately, very few people are on dabigatran. What I want you to remember as sort of the Allen key that works for everything, including warfarin and DOACs, is PCC, prothrombin complex concentrate. We now have many more studies showing that it is equally effective for temporarily reversing the anticoagulant effect very effectively, often within as short as 1.5 hours. So it's cheap and it's cheerful. And if you're going to pick one drug for your P&T committee, this is the one to pick. When should you resume a DOAC after a GI bleed? Again, very limited evidence to suggest what the appropriate timing is, but in the elective setting, we know that you should be resuming DOACs the day after a procedure. And it makes sense because these drugs have a very short half-life. You do not want to extend a period of temporary interruption unnecessarily because that puts the patient at cardiac risk. So what do I recommend? Resume the DOAC the day after the procedure in most. Now, if you have had a case like Dr. Bilal showed us where there's just one thing after another and you couldn't control the bleeding, the American Heart Association, the American College of Cardiology, and the American College of Gastroenterology all agree that you could probably have a little wiggle room for up to 48 hours before resuming your agent, and that should give you sufficient time to make sure you lock down that GI bleed if you need to go back in. One quick note about antiplatelets. It's really important that in the setting of GI bleeding for patients on phenylpyridine agents that you stop giving platelets. We know now, without doubt, that the provision of platelets to patients who are on antiplatelets and have GI bleeds increases the risk of mortality. We see that in the GI bleed literature, as well as the cardiovascular literature and the cardiovascular surgery literature. So when could you consider giving platelets? Well, the American guidelines do not give you a threshold level because, quite frankly, there's no good data to inform what that level is. The Europeans and the Asian guidelines say anywhere between 50 to 100,000. Americans went down the middle and said, if you think that the patient needs platelets, you should have a multidisciplinary discussion because you need to make sure the patient is aware, as well as the team, that that risk of platelet-induced death is real. But if there are certain considerations where the patient's got very low platelets and an emergency endoscopy is needed for a GI bleed, that should be an individualized decision. Please stop discontinuation of cardiac aspirin before GI bleed procedures, okay? We now have more than sufficient good randomized control data showing that stopping cardiac aspirin, that is aspirin provided to patients who've had a heart attack or a stroke, so not for primary prevention, but for secondary prevention, continuing that is actually confers a mortality benefit. People die when you stop their cardiac aspirin. So you can do all your endoscopic hemostatic maneuvers safely and effectively on cardiac aspirin. What to use? I'm not going to belabor this because this has come up before, but I want to dispel some urban myths. It is very safe and very effective to use thermal therapy in patients who are on antiplatelets and anticoagulants. There is no increased risk of rebleeding associated with thermal therapy. Get very comfortable using argon plasma coagulation because most of these cardiac patients will have arterial venous malformations, and APC is an incredibly effective tool for ablating these, and I would encourage you to ablate non-bleeding lesions. Why? Because these patients will chronically be on their drugs, and they will, if you do not ablate the non-bleeding lesion, you will be seeing them back in a few months with the obscure occult GI bleed. All right, and that gets them off the merry-go-round and of obscure occult GI bleeding bidirectional endoscopy. And mechanical hemostasis, as you've already heard about, is very effective for GI bleeding cases, and it's actually my preferred strategy in a patient with antiplatelet and anticoagulants, because that mechanical hemostasis, if used correctly, can have a durable hemostatic effect that's very beneficial, and you can really get those patients back on their drugs quickly. We don't know enough about hemostatic powder efficacy in this patient population, but there are ongoing studies that should better inform us in the future. So hopefully the results in a patient on antiplatelets and anticoagulants will be just as effective for malignant bleeding as we have seen for those who are not on these drugs. So here are my take-home points. When it comes to an anticoagulant bleed, you want to triage the patient first. Do they have a life-threatening bleed or not? If they have a life-threatening bleed, it's only in those patients that you should be even considering the use of a reversal agent. If the patient has a warfarin life-threatening hemorrhage, you want to use PCC, not vitamin K, and definitely not FFP. Do not delay your endoscopy until the INR is normal, because that just delays an important intervention for a cardiac patient. No routine reversal agents for a direct oral anticoagulant. The choice of a reversal agent for that life-threatening hemorrhage is based on the agent, or if you only want to remember one, choose PCC. Stop giving platelet transfusions. Please, please, please. If you remember one thing from this, stop doing that. And finally, thermal therapy is very safe. We don't know about TC325, but stay tuned. Some studies are ongoing now that will really help. Thank you very much.
All right, our next speaker is Dr. Judy True. Dr. True is an assistant professor of medicine at Washington University in St. Louis and a prolific advanced endoscopist. She's going to talk about food impaction and foreign body ingestion.
Good morning. I want to thank our meeting organizers for the invitation to talk on food impaction and foreign body ingestion. So a lot of you may or may not know, but 80% of food impactions and foreign body ingestions actually pass without the need of endoscopic intervention at all. The majority of these actually occur in children, ages 6 months to 6 years. And I don't know how many of you guys do pediatric work, but even as an adult endoscopist, I am called in to assist pediatric GI once in a while. In adults, we often see food impactions in patients who are without teeth or with underlying esophageal pathologies. Foreign body ingestions tend to occur in adults with psychiatric disorders, developmental delay, alcohol intoxication, and those who are incarcerated. So I know we're not unfamiliar with these middle of the night calls. So in today's talk, we are going to be reviewing the best practices in pre-endoscopic assessment of these patients. We're going to determine the best timing of endoscopy depending on the clinical status, what was ingested, and where the foreign body is located. And then finally, we'll review the common tools that we have for food impaction and foreign body ingestion, and then what works best for what. So when a patient presents to the emergency department, it's really important to appropriately and quickly assess these patients because we have to determine, number one, what's most important to us, are we actually going to go in for these patients? If they can wait till the morning, whether an endoscopy is even warranted, and most importantly, actually, whether they need a surgical consultation. So obtaining a thorough history is really important. You want to know what was ingested, when was it ingested, and also when was the time course and what they ate last. Do they have a history of prior impactions and ingestions? Are they presenting with any pain? Now, I do want to note that when they are telling you the location of the pain, it actually doesn't always correlate to where the impaction is. Are they having any difficulty swallowing or breathing? Now, these are assessments, of course, to determine whether or not complications are occurring. What signs are they presenting with, especially in those who cannot verbalize what they're saying, and so are they refusing to eat? drooling, choking. And then physical exam, are they having any tenderness anywhere, swelling, very important, any crepitus or peritonitis. So these are, again, physical exam findings of potential complications. When a patient comes into the emergency department also, and hopefully they haven't gotten that knee-jerk CT scan that most patients do, the ED may call you and say, hey, do you want any imaging on this patient? In patients with a very clear history of a non-bony food bolus impaction, it is okay to go without any imaging. However, if you do recommend something, a plain film can actually give you a lot of information. It can tell you presence of any type of bony ingestion or impaction of foreign body objects if they are radiopaque. The location, is it in the esophagus, stomach, duodenum, or further? The size, approximately, configuration, if there's numerous, the number of, and of course, any complications. Have they aspirated? Or is there mediastinal peritoneal air? Is there subcutaneous emphysema? However, if you do suspect any complications from this ingestion or you see any of those complications on the plain film, a CT scan would be appropriate. Avoid any PO contrast. This contrast will make endoscopy extremely difficult. The other thing is that if you can never be certain if there's partial obstruction of the esophagus as well. So you have to be very, very confident that there's nothing in the esophagus. So I would avoid any type of PO contrast. But if you must, then make sure you use a water-soluble agent. This is probably one of the most important slides of today's talk, is going to be timing of endoscopy. You want to know whether or not you're going to come in for this procedure. I definitely want to know, if I'm getting called at 2 a.m., am I putting on my scrubs? So this is a table that I have put together based on the ASGE and ESGE guidelines, and I divided it into emergent, urgent, and non-urgent. And then I also divided it between where the suspected impaction or location is, the esophagus, stomach, or proximal duodenum, because this will also guide you on when to come in. This is going to be the only part that's going to be emergent. These are the only objects that are going to be ingested or impacted that you should come in, as the experts recommend. It says up to 6 hours, but as soon as possible, because as we all know, getting an OR room, getting anesthesia, it can take up to 6 hours, but this is something you say needs to be done. So if there is complete obstruction, if they can't handle their secretions, very important to come in. Disc batteries, if confirmed on history and plain film, these disc batteries have increased risk of perforation once that necrosis starts. Any sharp objects in the esophagus as well. You want to go in and remove it before it causes any type of perforation. These are your urgents. Say up to 24 hours, but of course, please assess what was ingested, the location, and then the patient's clinical status as well. So non-sharp objects in the esophagus, and then incomplete obstruction if it's a food bolus in the esophagus. If objects are in the stomach, sharp-pointed objects should be removed within 24 hours, so you could say we can wait till the next morning. Magnets within reach as well. So sharp-pointed objects and magnets within reach also, I would say go in as soon as possible with magnets. You could prioritize it for the first thing in the morning. You don't want it passing the pylorus or out of reach. Sharp objects, of course, if it's something pointier that from the history, if they swallowed scalpel tip was something I read about, I would probably go in sooner rather than later. Same thing for the proximal duodenum. You can also wait probably until the morning for sharp objects and magnets within reach. Anything longer than 6 centimeters, and you'll see it's very rare for something longer than 6 centimeters to pass the pylorus, but if it does, then it's going to be very difficult to make that duodenal sweep. High risk of perforation. So I would wait only up to 24 hours sooner rather than later. And then your non-urgents. This is going to be the last part of the table, the non-urgents. Anything that is greater than 2.5 centimeters in diameter, unlikely to pass the pylorus. Of course, if it does, then you can let it go unless it's greater than 6 centimeters. But anything greater than 2.5 centimeters, unlikely to pass. So you may want to go in after 24 hours if it hasn't passed yet. Batteries, most of the time it will pass. But if it hasn't in 48 hours, then you definitely want to remove it because there's a chance it may not and then start to break down in the stomach and cause gastric injury. Now, going back to this, any objects that don't meet this criteria, you can safely say, I will monitor it and just do, especially if it's radio opaque, get a plain film every 4 days, 3 to 4 days, even as an outpatient, just to make sure it's past the GI tract. Now, preparing for endoscopy, what to do and what not to do, or to do or not to do, I should say. The biggest question is, do you give glucagon? That's always a question in our training, do you give it or not? So originally the data back in 1970s, there were a lot of bigger case series that said that using glucagon actually helped pass the food bolus or foreign body in about up to 50 to 60% of cases. However, newer studies out in early 2000s, including a randomized controlled trial, shows that it is not very effective, not compared to placebo. And then also patients who have meat boluses as well as underlying esophageal pathology, actually it doesn't really work at all. So the experts in our guidelines suggest that it is relatively safe, but it should not delay or replace an upper endoscopy. Next is intubation. Typically, this is a resource that, if you're lucky to have anesthesia on call, that's fantastic. But these are the things I do like to discuss with my anesthesiologist when a patient comes in with a food impaction or foreign body ingestion. What was ingested? Where is this impaction located or foreign body located? When did they last eat? How is the patient doing clinically? If they've aspirated, you definitely do want to, put a breathing tube in. And then how do you anticipate the procedure going depending on what they ingested? Are you anticipating if it's a food impaction and they had a tuna salad earlier, you're going to be probably going in and out quite a bit, and so you may want to be able to protect that airway. Or if they swallowed something sharp, you may want to be able to protect especially the upper esophageal sphincter. Now, food impaction and your foreign body toolbox. I think that any GI group who takes call in the hospital needs to have a toolbox. This will consist of all the tools that you may not use all the time, but then you'll have it at your disposal whenever you need it. So, and most of these cases will take place in the OR, in the ICU, in the ED, and you don't want to be running back and forth to your GI lab and trying to remember what you need. So a toolbox is really important. What should be in your toolbox, and not every places have everything, but it's good to have things when you need it. So the first is your overtube. Not a lot of, most places do have this, but I do suggest that this is an important tool to have. So they come in 2 different sizes, your esophageal and the ones that expand past the lower esophageal sphincter into your stomach. And then I want to point out there's your standard and your therapeutic ones too. So this is important because you need to know if you're using a standard scope or a therapeutic scope. If you think, oh, well, why not just use the bigger one? If you use a standard scope with your larger overtube, you risk trapping mucosa between the scope and the overtube itself and causing a large laceration wherever you pass it. So things to keep in mind. Your different forceps, whatever your hospital allows you to carry, but then also your different grasping forceps here. These are retrieval graspers. You've seen these, I kind of call them like my claws. So like they're long wired prongs with little feet at the end. These are really good for soft things. We'll go through things that work better with different ingestions. You have your different nets, your snare. You may or may not have this, but you could talk to your interventional folks. These are retrieval baskets. They're usually used for stones in ERCP, but these are really, really good for your soft food boluses. And then, of course, your rubber or latex hood for sharper objects. So We talked about, so we'll go through food bolus first, which is, my anesthesiologist always asks me, how long do you think this is going to take? I'm like, it could take 20 minutes. It could take 2 hours. Like, you just don't know. It depends on what they ate, what you're going to see in there. They could have eaten for like 3 days and said, oh my gosh, like I've been feeling this discomfort for 3 days now. And you're going to be digging through a huge, esophagus. So before we get into the types, I do want to say that in larger case series, over 90% of the time, the push technique works. So what you want to do, especially when you go in there and you want to just try gently pushing forward first. Not hard, but just gently. It might start moving forward, especially if it's a small bolus right at the distal esophagus. The key is to actually push on the right side because the fundus is going to the left, so then it's actually going to give way a lot easier. So you push there. If it's not giving way, the experts recommend just kind of starting to end block remove and loosen up, and then potentially then start pushing forward again. So that works in over 90% of the time. There's a lot of great data on transparent caps. So what this does is that it increases the rate of end block removal because of the suction ability and kind of ability to remove larger parts within the cap itself. Now, a lot of places, the caps that we tend to use are actually designed for EMR or endoscopic submucosal dissection. Now, if you don't have that in your toolbox, that's okay. A bander is actually very easy to use. You just put on the bander kit, take out the cap, deploy all the bands, and then you put it on and you have a clear cap. So that's a very easy thing to use when you don't have the other tools and you're at your disposal. Now, we're going to go into the types of foods that may, were the tools that may help the best. And so we have your hard and chunky, right? And so you have your steaks, your bones. Grasping forceps are really good for that, your baskets and your snares and nets. Soft and stringy, so I was talking about the tuna, the poultry. Your retrieval graspers are really good at clawing at that. And then your baskets and nets and snares as well. Blunt objects, so you have your short and long blunt objects. The thinner, smaller ones, the forceps, the nets and snares are really good. If it's, batteries are much smoother, so you may want to use, it's hard to grasp at, so you want to use more of your nets and snares. Irregular toys are also really good for your snares. Long blunt objects, so your spoons, your toothbrushes, grabbing one tip of it, and then especially in the esophagus and pulling up is great. Use your overtube as well if it's past in the stomach. So then that way you just kind of pull a little bit into the tube and then you pull the entire thing out. So then you help. So then you don't lose grip of your object within the tube itself. Sharp objects. So some common sharp objects, especially in your incarcerated patients, you want to grab the non-sharp end first so that the sharp end is trailing if you have that capability. The hoods are great, especially if the object is in the stomach. You grab your non-sharp end, if that's an option. As you pass the GEJ, the hood deploys around and then protects your lower esophageal sphincter, the esophagus, and your upper esophageal sphincter. Of course, your overtube, use whatever you can grasp within the hood itself as well. Narcotic packets, do not try to retrieve this. So you have patients who are body packing, and that means either swallowing drug products. These do not try to intervene upon because they may break. Now, you can monitor with imaging if you're able to. Bowel irrigation is good. Surgery if it does not pass, and then, of course, medical toxicology if it breaks. And then thinking outside your toolbox. This is what I love. Look at your case reports, look at your video publications, see the innovative things that are people doing off there. It's lots of off-label stuff, but it's great. Talk to your colleagues. They have a cumulative experience. And then talk to your industry reps because there are actually dedicated foreign body retrieval devices out there that may help. So in summary, a thorough history and physical examination is going to guide your management. Plain film is good enough, and it's fast and cheap. And then the location and what was ingested will help you determine your timing. You do not need to go in the middle of the night for everything. Thank you.
Thank you, Dr. True, for this fantastic presentation. Our next speaker is Dr. David Wan from Weill Cornell in New York, and he's going to talk to us about lower GI bleeding.
Thank you to the AGA and the course directors for inviting me. It's truly an honor to be here. I have a confession to make. I must admit, acute lower GI bleeding management is one of the most frustrating things that I have to deal with. And it's a clinical conundrum. I'm a GI hospitalist by trade, so over the last 15 years, I've seen hundreds and hundreds of cases, and I still go into it with this level of consternation, frustration. And so over the years, I've tried to develop a methodology using evidence, using my own experience. So I'm going to share some of those hopeful pearls that you can take home.
You just do it on the screen and then
on the screen?
Yeah, on that other one.
Oh, yes, sir.
If you just click on that one and then.
Okay, thank you, sir. I have no disclosures.
Yeah.
These are my disclosures. Sorry. And so I break it down into the 5 Ds. So these are why acute lower GI bleeding is challenging. So the first D is, it's mostly diverticular bleeding. So, you'll see that over the years, diverticular bleeding has been shown as the number one cause, and you'll see it's even increasing given the age of our population, the use of antithrombotics, as Dr. Abraham mentioned. The second D is that because it's diverticular bleeding, the natural history is actually quite hard to predict. It's hard to know who's truly safe and you can discharge. It's also hard to know who is going to have bad outcomes, who's going to rebleed, who's going to need intervention. But the good news is that 90% of them is spontaneous resolve. But it can be severe, and rarely it can be life-threatening. And the other frustrating thing is that it's really hard to predict rebleeding rates, even within the hospital. How many of us have had patients ready to go and they bleed right before they leave the window? You got to say, what do I do now? I'm back at square one. And even after they leave the hospital, they have a rebleeding rate up to 35%. The other thing that we all, and I find very frustrating, is it's really difficult to find an intervenable target. And if you look at large prospective and observational data, it's only up to 8% of the time. And so because of that, since we rarely find something to treat, we don't know how to deal with it. There are actually no RCTs to know what is the actual best endoscopic therapy. And actually, it's quite technically difficult to do. So you don't have experience to do it, and you don't know what to do. It leaves you with challenges. And lastly, the fifth D, as Dr. Abraham mentioned, is it's really hard to know what to do with the antithrombotics because we don't have RCTs. We don't know what to do. But actually, this is maybe the most critical decision in terms of mortality. But we have to tell the teams what do we do with the AC or the antithrombotics. So hopefully by the end of this talk, you'll know and have a better understanding what is really the most rational approach to patients with acute lower GI bleeding. Like I said, the first D is diverticular bleeding. Because when you look at all the different cohorts, diverticular bleeding always comes up on top. And it's always presumptive because truthfully, how often do we find stigmata of recent bleed? Otherwise, definitive diverticular bleed. And most of the times, you scope them, it's either completely clear, you see tons of ticks, or you see a lot of blood. And so you can say, okay, maybe if you've done a relatively good, thorough workup, you've excluded other causes, and you're left with this presumptive diverticular bleed. Thankfully, we've had other cohorts. There's a large Japanese cohort that really looked at 10,000 cases in patients who've got colonoscopy and CT scans pretty early. And so they have a pretty robust number. So it's about 64% in that cohort. So about 2/3 of your cases are going to be diverticular bleeding. And that's probably going to be the most important one because that's the one that's arterial. That's the one that's going to bleed a lot and maybe be manageable with intervention. All the other ones are important to note. Ischemic colitis, hemorrhoids, but you're not going to generally bleed out from those types of lesions. Other things like angiotasias, and so forth. Again, we're looking for the severe arterial type of bleed, and it's going to come down to diverticular bleeding. So when someone comes in to the hospital with lower GI bleeding, what do? You got to go back to the ABCs, the basics. So airway, breathing, circulation, get the good H&P, what's the nature of the bleed, what's the volume of the bleed, what's the color, is there clots or not, is there associated pain? Could the patient have, other comorbidities that impact their prognosis? Cirrhosis, renal disease, cancer history. What meds are they on? And so forth. The critical aspect is their hemodynamics. You got to dichotomize, are they unstable? If that's the case, you got to resuscitate them, give them blood. If they're stable, but their hemoglobin's below a certain threshold, you got to get them above that threshold, above 7 or above 8 if they have CAD. And of course, you have to manage their often ongoing anticoagulation, as Dr. Abram discussed nicely. But don't forget about the brisk upper GI bleed. Up to 15% of the time, hematochezia is actually an upper GI etiology. So don't forget to do an EGD if your pretest probability is high enough. And at the end of the first initial encounter, you have to decide, how do I risk stratify this patient? Where do I send this patient? Do I send them to the ICU, step down, do they tell the team to discharge the patient even? Do I get a CTA? Do I prep them or not? And when should I scope them? These are all not easy decisions to make. So in terms of risk stratification, just there's nothing that really has been shown better than clinical judgment. And truthfully, that's what it comes down to. So most of us here are GI doctors. We want to know, do we need to come in the middle of the night? What is the role of a colonoscopy in lower GI bleeding? So I like to reframe colonoscopy as we're not just there to to do therapy, but we also there to make a diagnosis. But you need to realize that it's rare. It's rare to actually find a lesion that you can treat. Even though most people, when I have medical students, they always think it's like 30%, 5 to 50%. I'm like, actually, I'm sorry, it's about 5 to 8%. But nonetheless, this is from a U.S. large insurance claims database where people got colonoscopies and they had lower GI bleeding sources, and they only received therapy up to 8% of the time. Other cohorts are down to 3%. In Japan, they have rates of up to 30%, although one has to understand in their healthcare system, they actually have they mobilize the patient, they get CTAs, colonoscopies. In this large Blue Jay cohort, they had 10,000 patients in 49 hospitals, and they looked at their SRH, sigmoid hemorrhage rates, and it went from 21 to 33%, and this is over the course of a decade and a half. And they've noticed that it seemed to correlate to using CT scan, using a distal attachment device, a clear cap, water jet irrigation, and so I would encourage everyone to use those adjuncts. But a sobering fact is that despite early colonoscopy, more SRH detection, and endoscopic therapy, and while there may have been a decreased length of stay, there was no change in rebleeding rates. In fact, in some of these studies, there actually was an increased rate of rebleeding if you scope them earlier. However, the benefit is that you do make a diagnosis up to 95% of the time. So it can help. You can certainly exclude colon cancer and things like that, other important diagnoses that you don't want to miss. Now, timing is always a big question. Do I have to wake up in the middle of the night, bump in the middle of the night? But the truth is, timing has been studied, although we only have 4 RCTs. So that when you compare urgent, which is less than 24 hours, to elective, greater than 24 hours, in lower GI bleed, when you look at and combine the RCTs and these meta-analyses, there is no difference in clinical meaningful outcomes. If you look at a couple of individual studies, there may be a decreased length of stay and some more SRH detection, but when you aggregate these studies, there actually is no difference. Although if you include a lot more patients in observational trials, you do see a signal, but based on the quality of the evidence, my quote, this is from not my quote, but my co-fellow, is that there's no such thing as door to butt time. And that still stands true to this day, even from my fellowship, 15 years ago. So I was part of the lower GI bleeding guideline and had the privilege of serving on that, and that is part of our recommendation. There's no need for urgent colonoscopy. So what if you do happen to find, and are fortunate enough to find, stigmata of recent hemorrhage? It does happen, and there are ways you have to think about it. But the truth is, it's not like the Forrest classification. I know Dr. Bilal talked about it. It's not analogous to that. There are some principles that we need to hold forth. Like, for instance, if you look at the middle column and the right column, in the middle column, you see active bleeding on the top, over here, and then you see here on the bottom, and here on the upper right. These are both stigmata of recent hemorrhage. Here you see it at the neck, and I'm going to emphasize that in the next slide for important reasons. And this one is in the dome. So location actually matters, and that's something that people don't realize. Another thing people don't realize is that what we call the flat spot, the heme spot, which we usually consider low risk in upper GI bleed, actually can be considered high risk in lower GI bleed. Dr. Jensen, who did a publication looking at using Doppler probes, found that 8 out of the 10 patients with a heme spot actually had positive arterial Doppler flow, and that if you let those patients go untreated, their rebleeding is up to 60%. So as I said, location. So one may be wondering, what do I do? If it's in the neck of the divertic, you may actually use bipolar or multipolar electrocautery. one may have pause, I'm going to perf the patient. But as if you know, and you've seen many patients with diverticulosis, it's actually quite thick. Their muscular hypertrophy here actually gives you a little bit of buffer, so you can cauterize an epi if it's bleeding, and cauterize as you would in an upper GI bleed in the stomach. You may want to be a little more gentle, and you may want to use shorter pulses and a low wattage, but you can still apply, and apply it laterally, so towards the muscle. And importantly, you want to mark the site with a tattoo, just in case it rebleeds. You know where to find it again and localize it. Now, what about if it's in the base? Actually, this is the more common scenario. About 55% of the time, the stigmata, if you find it, it's going to be in the base. So it's important to recognize the actual microanatomy. You actually have feeding vessels from the submucosa and subserosal side and an artery that's usually a branch of a mesenteric vessel. And actually, these are bidirectional flow. And of course, life is in 3D, not in 2D. But so you do your best to try to find the stigmata of recent hemorrhage and clip it. So you cut off the feeding supply. And so that you have to try to hit it directly or kind of flank it from both sides. Well, that's easier said than done, I will admit. And the truth is you can see, you actually want to do direct placement, not indirect placement. What is the difference? Directly, you just hit the stigmata or you flank it. Indirect placement is almost like just covering the hole, and you're relying on tamponade. You're not even cutting off the blood vessel. So as you would imagine, and studies have shown from Japan, that direct actually has less rebleeding than indirect. If you take it to the next level, so this is a video demonstrating how you could do that. It's easier said than done, but to increase your chance of success, this video demonstrates a couple of nice features. One is that there's a clear cap. You can see the clear cap, as Dr. Bilal mentioned, using upper GI bleeds. I use it in every lower GI bleed. It helps get the visible vessel right in front of you, right at the right perfect working distance. You can actually manipulate the folds a little better. And the other important point is the clip. And the type of clip matters. The toolbox has to use a special clip that has a narrow opening diameter and a short stem. Because if you don't, you can't work in those small little confines. And so here, if it's reopenable and if it's also rotatable, is also very useful. Now, sometimes that's not feasible. So if you take a page from the Japanese literature, they actually really focused more on banding, and this become much more popular in the East. And so when you look at the studies in the literature, prospectively, retrospectively, even in the meta-analysis, across the board, the bleeding rates are less with banding. Now, granted, as I said, a lot of these clipping comparisons are with indirect clipping, but nonetheless, in every study, banding wins out, where there's almost up to 13% decrease in rebleeding rates, and this is short-term, medium-term, and long-term. Now, you should appreciate that it's really the most beneficial for specific lesions that are actively bleeding, right-sided, and diverticular in nature. You may be worried could again cause any complications. Perforation is possible, but it's only up to 0.31% in this large cohort. And again, when you band these, you want to get it. It's similar to when you do it for varices in the esophagus. You want to get a good amount of tissue into your, cap, and turn the dial when you have a good amount of tissue. You create almost a nice neck. So you're really getting at the feeding blood vessel. What about the role of radiology? And so CTA has been proposed as an initial test. CTA has a lot of advantages. It's quick, available. You don't need to prep the patient, and maybe it helps predict and help localize your ability to localize stigmata of recent hemorrhage. In one large retrospective study, that was the case. Up to 68% of the time, if you did a CTA first and it was positive compared to if it was negative, you were more likely to find something to treat. That's a little more robust than I think in most other studies. In this larger study, the Claude Bouget trial, again, they had 7,000 patients, and 73% had a CTA, and 98% of who had a CTA did it within an hour, so quick mobilization. But even in that high throughput, they were able to only get 22% positivity rate. Depending on if you're a glass half full, glass empty kind of person, 22% is still a large minority of cases. But if they did find it, their stigmata of recent hemorrhage was about 31%. And so there was a more recent study that looked at actually in a randomized control fashion, the usage of urgent CTA and colonoscopy versus just going straight to early colonoscopy, although granted is in mostly stable patients. And so again, the CTA rates were relatively low, 17%, and there was no difference in stigmata of recent hemorrhage detection, endoscopic therapy, or any clinical meaningful outcome. So it's a bit up for debate whether or not CTA is still useful, but you can consider it as that could potentially help you localize lesions, but again, whether or not it changes the natural history remains to be seen. So in summary, if someone comes in with severe hypocasia, resuscitate, transfuse, those are things that have mortality differences. Exclude an upper GI bleed source if the repeat test probability is high enough. If they have mild bleeding or the bleeding has subsided, you do not need to wake up in the middle of the night. You can wait for the next available colonoscopy. Use a split dose prep, please. And also, I didn't mention it earlier, but if the patient has had a relatively recent colonoscopy, let's say within the last year, and is high quality, and you rule out colorectal neoplasia, and also, alternatively, if they've had diverticular bleeding, you've scoped in multiple times, the bleeding seems to have subsided, and you're pretty sure it's another diverticular bleeding, and you think the risk is relatively high, you may want to forego the colonoscopy again. Though, on the other hand, if you have ongoing significant bleeding, you get a CTA. If it's negative, again, you can wait till the next day, prep them, go for a colonoscopy. If it's positive, and it kind of depends now on your local expertise. Many of us have IR, 24/7. Some places don't. If you have IR, it's important to be very well coordinated with them because studies have shown that if you act on a positive CTA within 90 minutes, your yield is 4 times higher. If you wait for the next day, you kind of lose that window. So you need to be in close coordination with your IR colleagues. If in a very rare circumstance, this is kind of where Dr. Abraham was saying the life-threatening hemorrhage, you may want to consider an urgent colonoscopy with a rapid purge PIP. But I'd say I can't even remember the last time I woke up in the middle of the night to do a colonoscopy because most of the time they're stabilized. Most of the time you need time to prep them, and most of the time, you can wait to the next day very safely. That. Thanks for your attention.
Our next speaker, thank you so much, Dr. Wan. That was a fantastic talk. Our next speaker is Dr. Mariam Naveed, who's a GI Fellowship Program Director at Advent Health in Orlando and one of the leading medical educators in GI. She's going to talk about colonic distension, management of colonic volvulus, and acute colonic pseudoobstruction. She's also the lead author of the guidelines on this topic. So.
Thank you. Thank you, AGA. Thank you to the moderators and course directors. I'm so sorry you had to listen to all those exciting talks to get to this. I know this is what everyone's waiting for, right? How do I take care of volvulus? All right, I'm going to try my best to make this exciting, though I do not have exciting videos, but I'll do my best. So my topic today is management of colonic volvulus and acute pseudoobstruction. Am I pressing here? Where do I press? This button?
Yeah. Should be good now.
I'm just going to stop the title slide. Which mouse am I clicking? Can I just hit here? Okay, all right, perfect. I have worked with Olympus before, so this is my only disclosure. All right, my objectives today are to do mostly a case-based discussion of evaluation and management of volvulus, really focusing on sigmoid volvulus as well as acute colonic pseudoobstruction. All right, so let's set the stage, right? You have a really peppy ED doctor calling you at 10 p.m. because they are just starting their shift. And it is in the middle of the night, and they call you with the patient 66, nausea, vomiting, severe lower abdominal pain, pressure for a couple of days now, inability to pass stool or gas for a week. They're tachycardic, they're tachypnic, visibly distended abdomen, tympanic on percussion, rectal vault is empty. They also throw in that FOBT is positive just because, just for fun. And FOBT is positive in case you wanted to know. So what is this? What is this scenario? So this is obviously a classic case of sigmoid volvulus, right? So this results from torsion of a redundant segment of colon along its mesenteric axis, and most commonly you see this occurring in the sigmoid or in the cecum. Now, narrow mesenteric barrow and elongated floppy loop make the sigmoid colon particularly susceptible to twisting along its axis, so majority of the time we're actually seeing this in the sigmoid colon. So X-rays may be used for diagnosis, and often they'll reveal this coffee bean or bent inner tube. You can see that on the top right over there. But plain-film imaging is diagnostic only in 60% of patients who have volvulus. And so whereas CT has actually shown to be diagnostic nearly 100% sensitivity and greater than 90% specificity. So as such, contrast-enhanced CT has really replaced plain-film imaging as well as water-soluble enema for being the preferred diagnostic study. Now, and so this is the coffee bean sign that I was telling you about. When you get a CT, you may see this distended or dilated colon that is there proximal to the point of obstruction. You may also see these signs here. So this is a whirlpool sign, and essentially this results from swirling of mesenteric vessels and fat around a central point. Now, when you see this, you should be concerned about this possibly being a surgical emergency, especially if there's any evidence of ischemia, because then you really want to think, is there any vascular compromise that's occurring? Now, just to kind of shift gears and really focus in on sort of the treatment algorithm, of course, it goes without saying that you want to start off with a general workup, right? Look and see if there's any anemia, electrolyte disturbances, elevated lactate, any evidence of acute kidney injury. And then really think about, are there any indications for surgery for sigmoid volvulus? So if there's perforation, ischemia, peritonitis, obviously you're getting your surgeon involved at that time. But in the absence of any colonic ischemia or perforation, then the first-line treatment of sigmoid volvulus is endoscopic evaluation. All right, I'm going to take just 1 second to actually talk about cecal volvulus, and I'm not going to really spend more than this slide on this topic because endoscopy actually does not play a significant role in neither the evaluation nor the management of cecal volvulus. Now, typically, cecal volvulus involves a true torsion, so a clockwise twisting of the cecum, the TI, as well as the ascending colon along the mesenteric axis. And the twist usually occurs around a fixed point near the ileocolic pedicle. So it really limits the mobility of the segment. So unlike the long, redundant, floppy sigmoid colon that I was talking to you about, the cecum mobility is really restrained. It's really constrained. So it really makes the torsion technically difficult, if not impossible. As such, the major treatment modality here is surgical management. I've had some of my colleagues, some of the surgeons will call and say, well, I still want you to do a colonoscopy. And I'll say, well, I wrote the guideline, no. It's happened. It's actually happened. I don't throw that in there too often, but every now and then you have to flex. Okay. All right. So there are not many GI who actually do rigid sigmoidoscopy. I don't actually know anyone, but again, these are our surgical colleagues. And so flex sig is really preferred over rigid sigmoidoscopy, and for multiple reasons. Starting off with superior success rate and safety profile. I have this study here just because I think it's important, especially for the trainees in the room, to understand why. Why is it preferred rather than just saying, well, it's preferred, but I'm not 100% sure. And this is actually one of the largest series in the world from Turkey that retrospectively evaluated nearly 900 patients with sigmoid volvulus over a period of nearly 40 years. The mortality and complication rate is highest in those patients who received barium enema and rigid sigmoidoscopy compared to those who actually underwent flex sig. So in addition to the superior success rate and safety profile, you also have that adequate length that's there with your scope to be able to reach past that constricting point. It also allows for better visualization because you also want to confirm that there's no evidence of colonic ischemia. And then this way you can actually guide the decompression procedure a little bit more ideally. And then of course, for us as gastroenterologists, we're more familiar with flex sig. And so, the better you know your tools, the less chances of complications. So the endoscopic appearance of sigmoid volvulus, when you initially insert the scope, you're going to see this whorl sign. And what you're looking at is actually, you're seeing the distal point of obstruction first. And there are actually 2 points that you'll see. So the first one is what you'll see here. And it's referred to as a whorl sign, obviously. And in between the distal and the proximal points of torsion, the colon is dilated as a result of closed loop obstruction. You can kind of see that a little bit more on that, on the other image. And then as far as how you're actually reducing the volvulus, so you're inserting the scope, as I mentioned, you're initially seeing that distal point of obstruction. And then you want to gently pass the scope through that twisted segment or that apex of converging mucosa into the dilated colon. And if you're successful, then you're going to see that second image here where the colon looks really distended. And then you really want to aggressively decompress that segment. And you do want to continue to advance and ideally go beyond that proximal point of torsional obstruction. And hopefully by then it sort of results in spontaneous detorsion, though at times you may have to clockwise rotate and kind of shorten the endoscope as well to really be able to reverse that twist that occurs. And at that point, it's quite apparent whether you've been successful or not, because essentially when you untwist, you're gonna see that there's marked gas and fecal material that kind of erupts around the scope. Now, the success rate of endoscopic detorsion ranges anywhere from 55 to 94%. It's really a broad range, unfortunately. But I think many of us are usually pretty successful at being able to reduce it. Now, factors that are predictive of successful detorsion are absence of abdominal tenderness, use of laxatives, and history of open abdominal surgery. Sorry, the surgery word is missing there. All right, so what is the role of decompression tube? Now, randomized control data is lacking, but both the ASGE guidelines as well as ASCRS guidelines do recommend placement of a decompression tube. And you want to place it proximal to the point of torsion after successfully detorting the area. And you want to advance it to, and the reason you're placing it is in an effort to kind of maintain the reduction and allow for continued colonic decompression. And usually it lasts 1 to 3 days, though I'm sure many of us have experienced this, like you put it in, they go to the floor, like patient farts, and it's like the tube is out and don't know what has happened. I think we've all experienced that. Now, there are two ways that you can place this. One, there's a dedicated decompression tube kit, and so there's that option. The other thing is you can actually attach a suture to the end and almost do like a piggyback technique where you're kind of guiding, you're pulling that decompression tube in with you. And so there are two ways to do that. Now, the risk of recurrent volvulus, unfortunately, is really high, up to 84%, even after we've been successful. And then when patients do present with recurrent volvulus, there's a higher rate of emergencies associated with that. And the mortality when you have a recurrent volvulus can be as high as 80%, especially if there's a colonic, if there's ischemia or the colon is gangrenous. And that really leads me into the timing of surgery. So ideally, when a patient comes in with sigmoid volvulus, there should be a surgery consultant at the same time, because elective surgical management or sigmoid colectomy or whatever the surgical intervention of choice is recommended in patients during their index admission or shortly thereafter. And ideally, it should be within 2 to 5 days of that initial volvulus being diagnosed and us kind of going in and performing our end. And I apologize, this chart is really, the writing is small, but that blue line actually represents those patients that have surgery less than 3 days after reduction versus those that were much longer in the red line. And on the other axis is probability of survival. So you can see that with the blue line, the sooner these patients were able to have a surgical procedure, the better their outcomes. And then in patients who are not candidates for surgery, advanced endoscopic techniques such as PEG, so percutaneous endoscopic colostomy and percutaneous endoscopic sigmoidopexy, have been suggested as management options. There are a small number of case series that exist that have really evaluated these techniques as a less invasive means to prevent recurrent volvulus, again, in those patients that are not surgical candidates. And both techniques essentially aim to fix the involved colonic segment to the anterior abdominal wall, essentially restricting its mobility and preventing a recurrent volvulus from occurring. Now, both modalities, unfortunately, have been associated with a really high incidence of immediate as well as delayed serious adverse events, including infection, tube migration, perforation, obstruction, abdominal wall bleeding. So you really want to be sort of mindful of who you're offering this in. But it's important to know that it exists, because for the right patient, this may be the best modality you can offer them. Now, fixating the colon has been performed using T fasteners or by doing percutaneous tube colostomy with or without laparoscopic assistance. Now, switching gears really quickly. So next day, you're still post-call, and then the ICU doctor comes in and says, "Hey doc, I have a distended patient. I think they need a scope." Usually by that time, I'm like, I think my medical director's in the room. I'm like, "Listen, I quit. I can't, I'm not, this has been a hard day. I don't want to do this. I'm not sure." That's pretty rough, right? Volvulus overnight, acute colonic obstruction the next day. Anyways, let's talk about clinical scenario number 2. So you have this patient who's had a knee replacement who develops abdominal distension and discomfort. She's been on a PCA for pain management, exam, distended abdomen, tympanic, hypoactive bowel sounds, and all the blood chemistries workup is negative. There's no concern for ischemia. And so in this case, imaging is crucial in establishing a diagnosis for acute colonic pseudoobstruction because mechanical obstruction needs to be excluded. And your cross-sectional imaging, usually when you're getting that, is notable for significant diffuse colonic dilatation without a transition point or an obstructive lesion. For the purpose of this case, let's just assume that the cecal diameter is noted to be 10 centimeters. And as I mentioned, the importance of imaging. Now, usually plain film radiography may be sufficient, but it doesn't always reliably distinguish mechanical from functional causes of obstruction. Now, one thing that's important to keep in mind is that mechanical obstruction rarely occurs in a patient that's admitted for unrelated illness, meaning like pneumonia or elective surgery. It's very rare that all of a sudden they're going to develop like that adhesion is going to be the thing that it acts up in that moment in time. So this way you want to consider pseudo-obstruction to be on your differential. So as we continue the scenario, the patient has an NG tube placed, rectal tube, bowel rest, IV fluids, symptoms don't improve, PCA has been weaned, and then when you repeat imaging, the colonic dissension is worse. So switching gears now for treatment, the goal is decompression. That's essentially what we need to do. And the therapeutic interventions in acute colonic pseudoobstruction focused on, as I mentioned, decompression of the colon, and that ranges anywhere from supportive measures and just doing conservative management to pharmacological therapy, through to endoscopic management, to, in some cases, surgical management. And where you start off in this algorithm really also depends on the severity of your patient and where exactly they're presenting. So there's nothing to say that you have to start there and all of a sudden work towards the end. So it really depends on what their symptoms are. But speaking of conservative management, you want to make sure that at that point you're making them NPO, that you're hydrating them. Cannot emphasize the importance of checking their electrolytes, making sure their sodium, magnesium, phos, everything is okay. And then making sure that the teams are aggressively resuscitating. I think so many times we see that, we'll see that the K is 3.2, and I'll specifically write down, like, you need to resuscitate and you need to improve their electrolytes. And the next day I come in and it's like 2.9. And I'm like, okay, well, we're not heading in the right direction. And so you really, really have to be kind of on the team or on the nurse to say, hey, this is really important. This is actually part of the treatment algorithm. At the same time, you may need to place in an NG tube or a rectal tube and really mobilizing the patient. So for your ICU patients, it may be just that we're turning them in bed and just kind of going from side to side. For others, really kind of making sure that physical therapy is on board if they're able to. And then removing any offending agents, so if they're on PCA or if they're on anticholinergics, or just really doing a good chart review to see is there anything that you can remove. Now, I want to just take a second to talk about adverse events because ischemia and perforation have been reported anywhere from 3 to 25%, so that it is something that can happen. And then the serial assessment of cecal diameter is really an important indicator of disease severity. So you want to make sure that there's serial imaging that you order to follow up on these patients. In patients who have a cecal diameter less than 12 centimeters, usually the risk is of ischemia perforation is 0%, 12 to 14, 7%, greater than 14, about 23%. So that risk can really go up. Now, for our guideline, the highest risk over 10 to 12 centimeters, and so these patients are considered high risk if you've had dilation greater than 12 centimeters and the duration has been greater than 6 days. Now, continuing along the algorithm here, in patients who have had no response to conservative management after 48 to 72 hours, then you can really consider medical management versus endoscopic therapy. Now, for medical management, I think we're all familiar with neostigmine, effective in approximately 90% of cases. And in patients who fail an initial dose of neostigmine or are partial responders or have a recurrence, it's perfectly okay and you should be giving a second dose because it's been associated with clinical response in up to 40 to 100%. And then at that point, once you've had successful response, giving daily administration of PEG via NG tube has been shown to decrease recurrence. Now, depending on your hospital setting, you may have to transfer the patient to the ICU because you do need monitoring, or they may need to be on the floor with tele. So there may be certain things that you need to do. But just kind of walking through what does that actually look like. The dose is 2 milligrams, IV infusion over 3 to 5 minutes. You want to have atropine available at bedside because there is the risk of bradycardia. Now, I don't know about others, but I will frequently give glycopyrrolate prior to giving neostigmine because it has been shown to decrease the side effects associated with that medication. So I usually do time it and I give it. And you want to make sure the patient is supine on a bedpan so that when you are successful, that you are nice to the nurses who are there and you stand clear and then, you let them do their thing. And you do need continuous EKG monitoring with vital signs for 30 minutes. So you really do want to be really wary of that. And then you do need continuous clinical assessment for 15 to 30 minutes during this time. Now, there are alternative routes. So there is some data suggesting that there is role for subcutaneous neostigmine, as well as continuous infusion neostigmine. And again, we don't have a lot of robust data, but there is still some that exists that's important to know. And there's some data comparing actually intermittent bolus versus continuous neostigmine. Now, the clinical response was similar between both groups, but the continuous infusion was associated with greater bowel diameter reduction at 24 hours. And the mean time to treatment was shorter in the bolus dosing group compared to the infusion. And the bolus dosing may be associated with decreased side effects. And I think that kind of makes sense compared to like the continuous group. Now, there are some additional pharmacologic agents that you can consider: oral pyridostigmine, methyl naltrexone. I would say Reglan and erythromycin, the traditional prokinetics, are really out the window at this time. Our guideline does not recommend the routine use of these medications. Prucalopride, not routinely. I mean, I think if you get really desperate, you can bring in a sample from somewhere, but it's not necessarily in one of the major ones that we lean on. I want to take a second, and I promise I'm almost done, to talk about Pomoros or methyl naltrexone, because for the right patient, it may be the answer, especially in those where it's opioid-induced colonic pseudoobstruction that's not responsive to neostigmine. I will try using this, and both of our guidelines do recommend that it can be used, so it's promising in select patients. And then finally, coming to endoscopic decompression, which is probably what we are all here to kind of talk about as well, initial and sustained colonic decompression from colonoscopy has been noted in up to 95% of patients. So as far as just procedure details, water infusion, minimal to zero insufflation, and you really want to use CO2 rather than air in these patients. And that makes sense, right? They're already distended. You don't want to go in and add more to that. You really want to be mindful of sedation. You don't want to give any agent that's going to further worsen that dilation. They have to be unprepped. And you want to at least try to reach the distal transverse colon before extensive suctioning of air. Now, the risk of perforation, because we're thinking, well, what if we go in, they're already distended, it's about 0 to 5% and a 1% risk of mortality in these patients. Now, in terms of medical versus endoscopic treatment, really limited evidence, no prospective head-to-head comparisons. There are some retrospective studies that have independently found that colonic decompression is superior to neostigmine. But what I would say is it's just not enough data to be able to flip the algorithm in the guideline yet. But there is some evidence that our patients may be better off if we go to colonic decompression first. And then again, in terms of role of decompression tube in these patients, both of our guidelines recommend placement, especially if the equipment and expertise is available. Getting to the transverse colon is sufficient, generally kept in place for 1 to 3 days, and then usually the patient passes it spontaneously. Low intermittent suction, regular flushing, and with normal saline to just kind of maintain patency of the tube. And then surgical therapy, this is very rare that we're getting our surgeons involved, but it can happen in a small percentage of patients, especially if there's any evidence of ischemia. So you want to keep that in mind. And the surgical mortality rates can be quite high. So if it's viable colon, 26%, perforated colon, 36%. And this is in comparison to like 14% with somebody treated with supportive therapy and 13% with our endoscopic treated patients. And I think it's important to understand the surgeon's perspective, because when we're calling them, we have to understand that there are risks associated with us leaning on our surgeons. I'm not going to spend more than a second on here. All I want to say is that this is a recent retrospective review, and what is nice about this study is that it actually shows that post-op mortality is lower than what we thought. And so that's nice, because we're not like sentencing them to death if we're sending them to surgery. So it's good to know that the mortality is lower. And then last thing, in terms of advanced endoscopic treatments for this group, again, there's the option of endoscopic colostomy to the cecum. They can be placed radiographically or endoscopically, success rates of up to 100%, but a lot of adverse events that are associated with this as well. Think about it. You're going in unprepped to be able to place this. And so there are a lot of repercussions associated with that as well. So my conclusions, essentially starting off with CT, abdomen, pelvis with IV contrast as preferred initial imaging, usually for both. For those patients that have any concerning findings, definitely get your surgeons involved. FlexSig with rectal tube placement for those that don't have any concerning symptoms at presentation, elective surgery to prevent recurrence, and then IV neostigmine for those patients who meet criteria, and colonic decompression for those who fail conservative management or have contraindications. And then to consider decompression tube in both cases. All right, thank you so much for your time.
Thank you, everybody. So we'll have a quick Q&A. just while the mic is in the center here, but I do have a very big recurring question for Dr. Abraham. How do you approach requests from cardiology about quote-unquote GI clearance when resuming anticoagulation or antiplatelet therapy after a GI bleed? What guides your decision making?
So that is not a straightforward question, but I'm going to give you a straightforward answer. All right? There's no tug of war between the heart and the GI tract. The heart always wins. And it is far more important to get the patient back on their antithrombotic drugs because that is life-saving. We can deal with a post-procedural bleed. We can deal with a post-procedural complication. You've already heard about all the tools in our toolbox. So do not let your nervousness about that delay your restarting of the drug. And trust me, that will be refreshing to the cardiologist because they are responding to your nervousness. So they won't ask you and they'll be delighted to hear, yeah, restart that 24 hours later.
Thank you. Do we have a question up there?
Sure. Yeah, my name's Tim, second year GI fellow. Just 2 questions on foreign body ingestions. Thoughts on safety of moderate sedation in esophageal foreign body ingestions? And regarding the timing of endoscopy, do you feel like your practice, your clinical practice changes if you're dealing with a patient with kind of recurrent intentional foreign body ingestions?
Great question. So the first one, for esophageal impactions or foreign body, if you know it's in the esophagus, actually a lot of studies show that moderate sedation is okay. I always talk to, did you say moderate sedation or conscious sedation? Moderate, yes. Moderate sedation is actually safe for the patient. I always talk to the anesthesiologist and CRNA though. The ones who know me and work with me very well, they know sometimes I'll do a quick peek in, and if it looks like something I could just push, then I'll do that. It'll take 1 minute of trying. If it does look like it's gonna take some time, I'll come right out and they'll intubate. So it's a very big discussion and things are dynamic. So I think that I work with your anesthesiologist. And then the second question was, yeah, I think that should also be okay as long as you're also then paying attention. But always have your anesthesia backup if things are sideways. And I'm sorry, your second question was recurrent.
Intentional.
Okay, recurrent intentional. Unfortunately, I know I've had this. You're like, oh my gosh, they're here again for the same thing. But unfortunately, you have to treat it the same way. What was ingested? Where is it located? Try not to let a lot of that emotion cloud how you treat that patient.
When you end your consult, encourage the psyche evaluation. I'm not being facetious because often there's an underlying psychological issue that needs to be addressed.
And then lastly, one thing we've done in the past when we used to work in a prison hospital is to work with the ethics team and develop an algorithm that's listed in the chart. And then when that person, if it's a recurrent, you have just an algorithm in place of what we're going to do, all those things. So, never an easy answer.
Yusuf Gagzi, one of the resident physicians at University of Illinois. I have 2 questions. The first one is regarding the lower GI bleed management in terms of use of CTA, and when do we prefer RBC TACT scan? Do we have any role of that in terms of colonoscopy? And second one, for the sigmoid volvulus, like as a physician on floors, do you have any like post endoscopy or rectal tube decompression cares in terms of ambulation protocol that we need to be aware about in terms of improving outcomes?
So regarding the role of a TAG red cell scan, well, oftentimes they're not readily available. CTAs everywhere. Anyone get a CTA the minute they hit the ER. TAG red cell scan, nuclear medicine, they're not 24/7, takes time. It has a lower threshold for detection, but again, it doesn't localize. CTA tells you where, right side colon, left side colon. TAG red cell scan is like what region. It doesn't really, and usually my IR colleagues want a CTA first because that predicts where they're going to target their artery.
Just to clarify, the question is whether there's any sort of like post-detorsion and they have the rectal tube placement, whether there's any restrictions for ambulation or any sort of algorithm in place. I mean, not necessarily. There isn't anything in place, and I don't really know if there's data to support whether you ask them to aggressively ambulate or not. Because if you think about it, versus like pseudo-obstruction, where we are a little bit more mindful, it has less to do with the sort of the squeeze, if you will, or the motility aspect. I mean, this is this is essentially sort of a flip of that colon for volvulus. So I don't necessarily advise them one way or another. For me, it's mostly, can you keep the rectal tube in? It's very difficult to ambulate a patient with a rectal tube in. And so that's not what I'm kind of focusing on at that moment. It's really kind of following their exam afterwards, getting surgery on board, and making sure that on imaging things remain resolved and that there is not recurrence. And really that the tube is in place where it's supposed to be, because often, like I mentioned, you think you've placed a tube somewhere and it's out. And if it's out, do your patient a favor, remove that tube. It doesn't do them any favors, and what they're going to do is develop a rectal ulcer if it just sits there in the rectum. And so don't just place and say, okay, I'm done. Make sure that there's imaging, because if it's useless, you're going to set yourself up for another consult for hematochezia for a completely different reason.
Question for Dr. Bilal. Great practical talk on bleeding. Just with the coag grasper, what settings do you use? And whether that will change with where the vessel is, and what size vessel you're comfortable going with a coag grasper.
That's a great question. So settings typically are soft coagulation, 4.5 to 5. And in terms of, it doesn't change based on the location. And then I think your last question, what size vessel you're comfortable with? Typically, as you saw the last video, the vessel was bigger than the coag grasper. So there's 3 sizes of the coag grasper. So, obviously for these kind of cases, I want the larger size. If I'm doing resection and stuff, sometimes you need a smaller size. But typically, the rule of thumb is if the vessel is bigger than the device, that you're using, especially for thermal cautery, then typically it's not going to work.
Hi, Dr. Naveed. I'm Alisha Nasser. I'm one of the fellows from Norwalk Hospital. With regards to the sigmoid volvulus, do you prefer to use a pediatric colonoscope or an endoscope when you're doing the detorsion?
Good question. I actually like pediatric colonoscope, because an endoscope is just really floppy. And so my preference is just to have a little bit more of that rigidity kind of help me. And because then it just gives me a little bit more length to kind of play with. Usually an upper endoscope is sufficient if you don't really have any other option. But in general, when I'm doing flex sigs, I prefer the pediatric colonoscope. And so that's what I go with. So I don't know if anyone else is.
Is there a particular diameter of the volvulus that you want to intervene on earlier? For example, if it's dilated to 6 centimeters, you want to do it in the middle of the night versus 10 that you
with a volvulus?
Correct.
No, not with the volvulus. I mean, usually when it's there, it's not something I sit on. Okay. And so when there is a volvulus, I'll say, okay, I'll come in. I'll tell you what's happened. Actually, I had a recent case of this where radiology sort of called a partial volvulus, and it was a little bit unclear. And so I went and scoped the patient, and the patient, and one thing I mentioned that the rectal vault is empty. That's not always the case. So that's not like a something that's set in stone. And so the patient actually had stool, and I could not find that. I was talking about the whirl sign, the point of the twist. And in that situation, I was able to get through really poor visualization, but nothing that looked like a volvulus. And I called radiology, and I was like, I don't know what you're seeing. I was like, I am not seeing a volvulus, but I really have poor visualization. It was one of the first times I'd actually ordered an enema and I had my surgeons on board as well. I had called colorectal surgery, and I said, I don't see a volvulus, but I want to be able to see if it kind of gets through. And the patient actually had just significant fecal impaction. And so that it was giving that appearance, and neither of us could find it on imaging. For all the trainees in the room, get practice reviewing your imaging. Know your imaging. Yes, of course, our radiology colleagues are there. We rely and we trust them. But don't blindly trust. Like, take a look, and what you're not seeing on endoscopy, look at your CT. And so sometimes I'll see that, but there's no diameter per se that makes me want to come in sooner or not.
Thank you. Just really quick, there's a lot of questions for Dr. Wan about over-the-scope clip and diverticular bleed. What are your thoughts?
Yeah, it's a great idea. I think conceptually, it's for those of you who use it, it's just the same thing as you do an endoscopic esophageal variceal banding. And so there are a few cases, it's at the level of case series and case reports, but it is durable. It gets really at the root, theoretically the root at the feeding vessel, and people are semi-comfortable with it. So I think it's a good option as well for those in the sigmoid in the dome of the diverticulum.
Thank you. And then we'll take the last two questions.
Good afternoon. I practice in Phoenix, and it seems like everybody that comes in with GI bleeding gets a CTA, no matter what their hemoglobin is or rate of bleeding and whatnot. And most of the time we get called after this positive CTA, they're called IR, and they're calling us to intervene. My question is that if you see like upper GI bleeding, do you scope them or you send them to IR? When you see a cecal bleeding, it could be angiectasia. Do you do a colonoscopy and send them to IR or send them to IR? So, I mean, a cecal angiectasia is really easy to deal with instead of exposing them to intervention. So,
Yeah, great question. So if it's locating to the upper GI tract, you treat it as if it was an upper GI bleed in EGD. It depends on the stability. Again, within 24 hours, ideally, they should be scoped per the guidelines. If it suggests a cecal angiectasia, certainly timing doesn't really matter. I think a colonoscopy would be the preferable way to go. There's a lot of uncertainty if you have a positive CTA. Is IR or colonoscopy the best approach? There really isn't a lot of data. There's studies that go both ways. Of course, IR is only useful if you have active bleeding, whereas colonoscopy is good if you have active or something that's not bleeding at the moment and could rebleed. So, timing is really key. I think in my institution, when we had a project we had radiology on board, even that a IR person was on the protocol, a lot of his colleagues didn't go in the middle of the night. And so it's problematic. So you really have to have a good relationship with your IR colleague to determine it's about communication. And because there isn't any true right answer. It depends on the scenario and your local expertise.
just to make sure I understand, for upper GI bleed, a CTA is positive. You still scope them. You don't send them to IR.
Yeah, because I think, as we know, and certainly the yield of a therapeutic yield of an upper endoscopy is quite high. We've done, we do upper GI bleeds all the time. You see oftentimes an ulcerative vessel or something that's actively bleeding, and using Dr. Palal's toolbox, we can really address those very well, better than IR most of the times, with less morbidity.
Thank you.
Final question. So this is pertaining to Biliaria's work and sphincterotomy for people on, DOACs and stuff. And I know the INR for less than 2.5 is good for regular endoscopy, but sometimes I worry if the INR is in the gray zone. Obviously, if the patient is sick, I can do a stent or something and temporize. But what level of INR, or would you feel comfortable proceeding? I use 1.5 currently, and I wait an extra day if the patient is stable. Also, sometimes I worry about doing a sphincterotomy in people on Plavix, because as you know, to stop it is 7 days, but I go ahead and do it. I do not hold Plavix for routine GI procedures for 10 years now, and I have not had any adverse effect in routine GI work, colonoscopy, polypectomy with Plavix. But sometimes I worry about with the ERCP and sphincterotomy. So any thoughts on that?
Yes, actually, there are a couple of really important points that you raised. INR is completely useless when it comes to DOACs, okay? An INR is not the correct serum assay to assess the level of anticoagulant effect. You need to use a drug-specific anti-factor 10A assay. Not always readily available, especially at smaller hospitals, but if there is one available at your lab, it's going to probably be for apixaban, because that's the DOAC with the largest market share. So INR of 1.5 or 10.5, it doesn't matter. It doesn't at all speak to the anticoagulant effect. Number two, you should never be holding your Plavix for 7 days. Oh, that's such a big mistake. It only needs 5 days. And yes, you should be doing your procedures with temporary interruption of Plavix. We have more than sufficient evidence to show that there's reduced morbidity and mortality risk by appropriate temporary interruption of Plavix and then resumption 24 hours later. So sorry to disagree with you, but I don't do medical legal work, but you would get in trouble if you had complications with either of those suggestions.
Okay, thank you.
Thank you, thank you. Thank you, everybody. There were a lot of questions we didn't get to. Apologize.